Thank you for the kind introduction, and good morning, everyone. At the outset, I'd like to thank friend Anjali, Steve Kerr, and all the HIV-NAT friends for inviting me, to do this presentation. I'm giving a very difficult task of doing this David Cooper Memorial Lecture. First, my, very deepest respect to this legend, which many of you here know that he has trained many of us, mentored many of us, and also groomed many of us. That's what today we're able to generate, this amount of science from this region of Asia Pacific. I don't want to talk much about David Cooper. Everybody knows, as you all know, that he was one of the co-founder of the HIV-NAT program, this Bangkok Symposium, and of course, he founded all the HIV program in the University of New South Wales, now called Kirby Institute, and had tons of publications. And he can talk on any topic related to not only on HIV and immunology. So today, I'm going to walk you through, some of those studies which had an opportunity to work with him and, published, and some of them, which he left as a research question, which we are pondering to answer those unanswered questions. I'm a little out of time, but I may, try to catch up. So as all of you know that here, these are the various antiretroviral drugs till today approved for use by the US FDA, and which many of the things which we are using in our own region, and recent one being these lenacapavir. And also, is for all the young clinicians who have been here today, for someone who's diagnosed with HIV, it's not like hepatitis B, you treat everybody, irrespective of the CD4, based on these two landmark studies, one for prevention, addressing on HPT and O52, and the other one on START. Again, on START, I'd like to tell you that David Cooper was one of the brain behind those protocol development. I still remember those days when he used to chat with us how this can be implemented in resource-limited setting, and had an opportunity to be an investigator of this study, and we contributed largest for the UNSW site from Chennai, India. So again, because of him, we are able to do the study in resource-limited setting, and today we are able to change guidelines for treating everybody. Having said all this, today, when you put someone on antiretroviral treatment, the ideal response is you suppress a virus and sustain the viral response. So that's something's ideal things what someone you need to see in a real situation. But on the other hand, what's happening is the common response is people tend to miss the pills, and because of that, the viral blips, and so we all know that it blips again and again, and they can develop a resistance. So this is something what we are seeing in our chronic population. And also for the younger ones here, you have been trying to get into these HIV therapeutics. So we have different definitions in the past for treatment failure. We had virological failure, immunological failure, and clinical failure. I just wanted to walk you through someone who fails. The first thing happens is a virological failure, followed by immunological failure and a clinical failure. This is something what definition we had used in the past. And also, there are modeling studies that had been done by our group, and others have shown the duration between virological failure to clinical failure can be anything from 6 months to 2 years, and from immunological failure to clinical failure can be even more than a year. And because of these definitions of immunological failure and clinical failure have become obsolete in HIV therapeutics. Now, what we all now follow is what is called the virological failure. And also, there are several basic scientists have already been alluded that the resistance mutation can happen even before the so-called, what is called the virological failure definition of 1,000 copies we use in our resource-limited settings. It can even happen even at a very low-level viremia, and if you are not switching therapy, and it can, harbor more and more mutation, can accumulate and jeopardize, various regimens. And just for understanding what is resistance, the billions of variants are produced daily, and these are all error-prone nature of replicating enzymes. And what are those mutations? These are all defective proteins which can alter the drug susceptibility. And all these drug-resistant strains may exist even prior to therapy, as shown by one of our earlier studies. So this is a clinical trial which I have been involved way back in the early 2001, 2002. It's one of the first NIH-funded international clinical trial by the ACTG group called PEARL study to show tenofovir lamivudine efavirenz is superior to AZT-containing therapy. So these are being recruited in sites like in Chennai, in Pune, in Chiang Mai, here in Bangkok, and several sites in sub-Saharan Africa, where we have never seen antiretroviral therapy in the before. It's not been used by any clinicians. So in those studies, after it was published, the samples have been stored, then baseline resistance was done by the Stanford group, and they're shown anything from 4.27% of baseline resistance mutations were seen. They've never seen any antiretroviral therapy in those regions when these trials have been initiated. So that means these resistance mutation can even happen before this therapy has been introduced. And also about this antiretroviral resistance, some of the basics. It can develop under the suboptimal drug pressure. Mutation can happen in RT gene, protease, and as well as in integrase. And once developed, they're permanently archived. It's not like an antibiotic resistance where you can still use it again for another episode. Some drugs have low genetic barrier. We have used a lot in the past, and we have stopped using that, like nevirapine and efavirenz. And it's got a class cross resistance. I think that's very, very important. And also some data have shown increasing degree if the patient continues on the failing regimen. That's something what clinician we need to know. We need to understand how quickly we need to change this therapy. This is again from data from one of our very earliest studies way back in the early 2000s when we didn't have viral load monitoring at our sites where we are using only CD4 and clinical monitoring. So at that time, we had collected specimens and frozen, and when resistant testing was been available, we went back to the freezers and studied their pattern of resistance mutation. What we have found in that is, in those patients, there are plenty of resistance mutations we've seen. And also other groups, including here from Bangkok, and as well as the Stanford, have shown when you have been continuing these regimens without switching, which can accumulate lots of mutations. In this particular study, we have shown almost around 25% of them had 3 or more NRT mutations, and almost 80% had MO94, and 60% had TAMPs, because we never used viral load monitoring those early years. So again, the failure of the first-line regimen, not to the current regimen, which I'm going to talk to you soon, the earlier one. So when the first one which happens is MO94 mutations, when it fails, followed by 1 or more of NRT mutations, and if we don't switch, then it can accumulate to K65 or we are using a backover L74V. So, and because of this persistent mutation, now you have seen the emergence of NNRT mutation as baseline of more than 10% in our region, and because of that, we have completely moved to newer therapy, which is dolutegravir-containing therapy. From now on, my talk will be pertaining only on dolutegravir resistance and how we are going to deal this in our clinics. So this is something you all know that when you have been diagnosed with HIV, you are going to use this drug TLD. And again, why you are going to use this is based on this single trial. Again, David Cooper was instrumental in constructing this protocol along with Sharon Vamsi, and they showed that it's been much superior as compared to efavirenz-containing therapy as shown by the yellow color curve. And also they have shown the virological suppression was much more higher, faster than this efavirenz, which is very important for the prevention effect. And because of that, almost all the guidelines moved towards initiating on dolutegravir-containing therapy. At that time, there's a question came from WHO and other international guideline makers, where is the evidence in resource-limited setting? That's the time in India we had an opportunity to use a generic Indian-made dolutegravir, where we studied this in our population quickly, almost around 500 odd patients, and showed that it has been very safe and tolerable, quickly suppress the virus, and we gave evidence to a very large public health program in our scale-up. Now today, following this first-line therapy with the TLD, patients still can fail if they don't take therapy, and there are data shows, this is a meta-analysis which has been published from various different clinical trials where they have used in patients who are in antiretroviral naive, where they use tenofovir, lamivudine, and dolutegravir, or in NRTIs and dolutegravir-containing therapy. The virological failure can be anything from 1% to 7%. But when they did this resistant testing, almost 0. So this is something what strikingly we saw very different from our earlier NNRTA-containing regimens, where it could be anything from 7 to 22% we saw in the NNRTI-containing clinical trials in treatment-naive population. But here, with this integrase, almost 0. Now coming to this, then why do you want to talk about switching therapy? Hey, if they don't develop mutations, we're going to continue them, ask them to improve adherence and keep doing this. I think that may not work, which we are going to see this now. Coming to the second line principle, I'm just going to again move to our earlier regimen of NNRTA when they failed. What we used was, again we used triple therapy, one from a new class, either integration PI if NNRTA was used, and we used 2 NRTIs from the backbone selected on the basis of resistant testing in resource-rich settings, or we speculated based on different studies in resource-limited setting following we have a public health guidelines. And again, either you can integrase or PI. But on the other hand, if you're using integrase as a first line, you can use a PI, which I'm going to walk you through some data. Before we go into that, we need to fix what best NRTIs you're going to use it. So today, when you have been failing with a TLE, we switched in the public health guideline to AZT containing therapy, then to along with an integrase or a PI. Why we use this is based on an earlier large surveillance program done by a group called TINA-RES group, where any patients who have been experienced with tenofovir when they failed, if they have K62R mutations, they contribute data to this large database in UK from different parts of the world, from sub-Saharan Africa, from Asia. In Asia, we had two sites. One is Chennai and another one is here, Bangkok, HIV-NAT. And we have Latin America and many parts of the world. So what's been shown in this particular TINA-RES studies in our region of Asia Pacific, almost around 39% of the patients, when they failed tenofovir-containing therapy, they had K65R mutations. And sub-Saharan Africa, almost around 50%. So that means at that time, guideline makers thought, hey, if you're going to recycle tenofovir to tenofovir again for second line, it may not work. And for that reason, they said, move from tenofovir to AZT or from AZT to tenofovir. So that's a time where we all know that AZT was highly been toxic. So we wanted to study in resource-limited setting, hey, if you're going to continue the same NRTI, or you're not doing genotyping, you just pick whatever NRTI, and along with the PI, whether it's going to work. So that's the time the second-line trial was constructed again. It's again, David Cooper was the brain behind it. I had a great opportunity to work on the protocol along with Mark Bard. He mentored us how to develop simple, clinical trial protocol for resource-limited settings. And along with that, there is an ACTG protocol, SELECT and EARNEST also studied, all studied on patients who have been failing NRTI-containing therapy, again, switching to a PI-containing therapy with lopinavir, or with a newer regimen of lopinavir and raltegravir. Again, in those patients who are switched to PI, where either the drugs were recycled or without genotyping, they're changed from one drug to another. Again, I just want to show only the second-line trial, which was largely, recruited from our region, very clearly shows that it's almost been comparable between the two NRTIs and a PI, along with a regimen of PI and integrase inhibitor. At that time, raltegravir was not being available. So in fact, this second-line trial was the basis behind what to do with this NRTI when they fail in first-line therapy. Can we recycle, or do we have to go to a newer regimen? So now it is now been well supported by the NADIA study, being studied in sub-Saharan Africa on a very large number of patient population of patients who fail in NRTI-containing therapy, where they've been randomized to tenofovir versus AZT, and also with dolutegravir versus darunavir. Again, also it has got another one randomization of patients to recycling tenofovir to tenofovir, and as well as switching from tenofovir to AZT. So again, I'm not going into the detail of this study fully because of lack of time. Just want to show this resistance profile. What the investigators very clearly showed is when patients who even had K65R mutations, and they had a higher virological suppression when, as compared to AZT, when recycled to tenofovir along with either dolutegravir or darunavir. So that means even if they have all this mutation, it doesn't matter with anything, you can recycle same tenofovir from first line to second line. This has again been well supported by our own DEF study. Here, Gail Matthews, protocol chair, has been here, who was the earlier speaker. So this is a well-constructed study. It has been largely recruited again in our region, where 48-week data was already been published. Very clearly have shown where if you have been changing from an NRTI-containing therapy, it's a 3-arm study where you used 2 NRTIs and a booster darunavir, and also another arm was a new regimen of dolutegravir and darunavir ritonavir. So that's a time everyone wanted to study, and as well as there is a request from the public health program to add a new arm of recycling tenofovir from first-line failure even to second-line, and along with dolutegravir-containing therapy. This again very clearly shows that the arm of TLD, when it's been recycled from the first-line failure of TLE, it's been non-inferior as compared to the standard of care of 2 NRTIs with booster darunavir. But on the other hand, the arm of dolutegravir and darunavir, which fared much more better And again, when we presented this on the 96-week data, last year at the AIDS conference, where we had shown which has been, superior as compared to, other regimens. But on the other hand, all these arms are been suppressing the virus very well. So that means when you are recycling tenofovir from first-line failure to second-line still works very well. So that means from the learnings from this depth study, if someone asks you what to do, someone who fails TLE, you can recycle to TLD. But also you can use a regimen of darunavir with dolutegravir, which has been much superior. And also, in this particular trial, we also found that a regimen of 2 NRTIs and boosted darunavir with 800, which has been non-inferior, to other, regimens. So that means it's very clear that, where we have plenty of options available, which one of them can be used when someone fails if we have been using dolutegravir as a first-line therapy. So now the question being, whether dolutegravir will develop resistance. I said earlier, you never develop resistance for first line. So now again, another meta-analysis has been published from various experience studies where patients have used dolutegravir or switched from a treatment failure to dolutegravir-containing therapy, where they have shown a resistance of anything from 2 to 3% being seen. And again, it is in the either monotherapy trials or even in patients who are already been treatment failed, where they have been highly viremic. So this is again a meta-analysis of various monotherapy trials where patients have failed various regimens like TLE, where they have been randomized to dolutegravir monotherapy, where they have shown in all these trials, they have developed harbored dolutegravir-containing therapy. So that means in your practice, don't use dolutegravir monotherapy. It will not work because it will end up in resistance mutations. So what about, when you have been using this therapy with dolutegravir in patients who are already failed with another regimen, which is highly viremic, what will happen? So this is again a data being published from Botswana, where not the dolutegravir mutation, but on the other hand, these patients were on dolutegravir-containing therapy, where they had studied on 100 patients who had been failed. Out of those, 83% were on dolutegravir remaining on non-dolutegravir-containing therapy. Out of those, 30% had a low-level viremia and 70% had virological failure, and 58 participants out of those 100 were successfully being sequenced, and out of those, 32% had drug-resistant mutations. Again, in this group, they have shown 33% had in the low-level viremia group, and as well as 32% in the virological failure group, and they clearly stated that dolutegravir-based therapy in the overall HIV-resistant mutations were 34%. These are all not darunavir mutations, but on the other hand, they were on dolutegravir-based therapy, but they had developed reverse transcriptase mutations. So that means, again, the carry-home message is, even while they're on dolutegravir-containing therapy, they can fail, and they can also develop mutation to the other background regimen what they are on, which could be a potential danger for the development of dolutegravir-containing therapy. Now moving to another very nice rapid scoping review by the Stanford group, which Bob Schaffer and the group, where they have studied on a very large number of records of 2,131 patients from 43 different clinical trials, 39 cohorts, and 6 cross-sectional studies. What they did is they divided into 3 different clinical scenarios, one on ART-naive patients who are receiving dolutegravir plus 2 NRTIs, another group on ART-naive with dolutegravir plus lamivudine, but they have been failed, another one on ART experienced with virological failure with the previous regimen, and another group on ART experienced with virological suppressed receiving dolutegravir plus 2 NRTI, and the 5th group of ART experience with virological suppression, another group on ART experience with virological suppression receiving dolutegravir monotherapy. Very interesting scoping review, and they found that very, very, very low level of integrase resistance mutations from these scoping review of 1.5% on ART experience with virological failure, but on the hand, higher prevalence at the DTG monotherapy. And they concluded that very, very, very low level of emergence with the integrase mutations. Now coming to these real-life situations, this is a data being published from Lesotho, from Africa, on 15,349 participants. Out of those, 157 had virological failure, and 85 of those were able to be successfully being amplified with various resistance mutations. In that, they have found almost 9.4% had dolutegravir mutations, and out of those, 7% had high-level dolutegravir resistance. So that means in a real-life situation, when you switch on patients who are already been failing with the regimen to a dolutegravir-containing therapy, they have a virological failure, there are a higher chance of developing a dolutegravir-containing mutation. So that means don't think that dolutegravir will never develop a mutation. It can develop, but there need to be some risk factors. What are those risk factors? This again, all of you know about that 39 million people living with HIV globally from the UNAIDS data. And also, just think for a minute, during the COVID time, we switched everyone who is on TLD, irrespective of the viral load in many regions, to TLD-containing therapy. Just like because we didn't have TLD was available. Everyone had been just switched out of those. And out of those, the 30 million people who are on globally on ARVs, 90% were on TLD-containing therapy. Significant amount of them from resource-limited setting, which switched from TLD irrespective of their viral load. Last year, WHO gave a very clear warning from their own surveys. They do a variety of surveys. They have been doing for years and years. Now, when dolutegravir scale-up happened, they furthermore strengthened, and some of us have been involved in this, and they showed it could be anything from 4% to 8.6%. And very recently, one of the reports have very clearly shows that almost 19.6% among the patients who have been experienced with treatment and transition to DTG-containing AR2 regimen having high viral loads have a higher chance of developing dolutegravir-containing mutations. So this is really bothersome, and I think we need to look into that very seriously. To study this in deeply, there is a large surveillance program being initiated by Matthias Jäger from University of Bern from Switzerland, along with a group of investigators from Sub-Saharan Africa, from Asia, and Latin America, and from Europe, a study called DTG resist studies. So this is what this study is. Patients who is on dolutegravir-containing therapy for more than 6 months who have been failing, they are subjected to a standardized resistant testing with an aim to determine the prevalence and patterns of spectrum of integrase mutations in adults and adolescents with dolutegravir-based therapy on failing, and as well as to identify the various risk factors, including drug host and health system factors, and also to do some correlation between genotyping and phenotyping in select sites. Again, it's quite a large study, just got 2 parts. The first part is already stored specimens. They did what is called collaborative analysis. This came from the cohorts called ART-CC cohort and IDA, and another one is a prospective study still being ongoing. Coming to this collaborative cohort, which has already been collected samples, which came mostly from Europe, from Canada, and some Sub-Saharan Africa, what they have shown in that is when they studied 599 patients with genotypic resistant testing, and out of those, majority of them subtype B, they found almost 22, that is 3.7% have major integrase mutation. Not much, but they were able to see these in this particular cohort with this variety of these major integrase mutations. Now, moving to this prospective study, which is a much watched study, not published yet, but I'm going to show some unpublished data on this. So what we have been doing in this, anyone who has been failing therapy on dolutegravir-containing therapy with viral load of more than 1,000 copies, after informed consent, they have been subjected to resistant testing. This study has been happening in 17 countries. In our region here, we have 2 sites. In fact, we have more than 2 sites. We have India, Thailand here, HIV-NAT. We also have a site in Cambodia, and several sites in Sub-Saharan Africa, Latin America, and as well as in Europe. Till last week, this is an unpublished data, 928 participants been enrolled, and this study has been funded by US NIH through an IDA program. So what's been seen, we have seen is, this is an unpublished data, so please keep it confidential. 48 participants with more than 1 major integrase mutation had been seen, which has been very alarming. These are real-life situations. So 1 or more integrase mutations have been seen in almost around 23% of those participants, and these are the most frequently seen mutations like E138, G118, L74, and T66. Also, we had seen N155, another signature mutations, and as well as Q148. So this is something very much alarming, not published yet, and you have been seeing for the first time. Please keep it confidential. And again, majority of the participants from this DTG resist is from lower and middle income country with subtype C. The earlier one shown in cohort CC is from subtype B. This has been, subtype C. So now, putting all these, whatever I've shown from various meta-analyses, published data, and from this unpublished data, so what could be the possible switching scenario when someone fails on dolutegravir-containing therapy, when you have been using, probably you can use recycled tenofovir and use darunavir 800, 100 from the learnings from the DEP study could be a possibility where you can use it. But on the other hand, when you're going to switch to third line, today what we do in a public health setting is change them to darunavir 600 twice daily and along with the dolutegravir. But here again, dolutegravir, if they have developed a mutation, I think you have to do a resistant testing. And again, you can recycle one or more of those NRTIs, or you may have to scout for newer drugs like lenacapavir, now shown being very efficacious. Studies have done both in naive population as well as in experience, where it works very well, and again, not exposed to our population. So it's been available currently as a subcutaneous formulation, as well as been validation going on as a per oral weekly medication, something we need to look for, or other medications like slatravir. Just before I end my talk, I think the future treatment strategies to combat resistance could be a long-acting. So I think everyday oral tablet, our patients are bound to fail. They're going to miss medicines and could have a virological failure, and they are going to develop resistance. Hence, we need long-acting medications to combat this resistance. For this talk, I again went back whether these long-acting medications have developed any resistance mutations. So it's again a data very recently published in CID. So what they have done in this particular meta-analysis is, patients who have been enrolled in any of those studies for this long-acting, mainly CAB-LA, rilpivirine, almost 33 studies of 9,000 odd patients reported virological failure prevalence. Out of those 19 studies, they reported some resistance data in this particular analysis. In those, the virological failure prevalence was 1%, which is very, very low in these long-acting induction maintenance studies, and 1% in switch suppressed studies, and 5%, very interestingly, in switch viremic studies. So that means somebody is viremic, switching, every possibility it can fail and can accumulate mutations. So in this, whatever patients who failed, which is again either 1% or 5%, when they did the genotyping, and what they found in that is integrase resistance was anything from 40% to 71%. So that means even if the virological failure is very, very small in this long-acting, when they amplify, they're able to higher prevalence of integrase mutations, that is to cabotegravir in this. And also in this, they also found that there's a cross-resistance to dolutegravir, because both the cabotegravir and dolutegravir shares a similar pathway, almost 64%. So that means there is a threat even for long-acting drug to fail and to accumulate these mutations. Now, another word about two-drug therapy. Now, everyone are very fascinated. Research, which settings already been changing? Research limited settings. We are in the process. We do have a generic formulation from India, where in our clinics we have been switching everyone to this 3-DTG. And again, I like to give a warning to all those clinicians. When you have been doing this, please use this on patients who have got a suppressed viral load, and try to repeat the viral load within 2 to 3 months. Make sure that they are virologically suppressed. It's very important. If they are viremic, there is a possibility DTG can be get. And don't use it in hepatitis B co-infected patients, which you all know that you need tenofovir or TAF. And in TB patients, don't do that because you have to double the dose of dolutegravir. We do not have enough evidence using this two-drug therapy. What about from prevention trials where they used cabotegravir? As many of you know that HP10-083, which was recruited a lot here in Bangkok, as well as in 084, where they've shown injectable cabotegravir is far superior as compared to oral tenofovir, emtricitabine for these as a PrEP. Again, in the arm of cabotegravir in HP10-083, there are 18 new incident infections were seen, and out of those, when they did some genotyping, 3 participants had developed cabotegravir resistance mutations. So that means even in a prevention study, if there is a breakthrough infection, or if there is an infection which is not diagnosed in PrEP trials, where if they continue these cabotegravir, there are possibility of developing these resistance mutation. That means, and again, now cabotegravir is getting scaled up in resource-limited setting as a PrEP regimen. If our testing strategies are not in place, there is a potential threat of developing this cabotegravir mutation, especially in those breakthrough infections. I'd like to conclude my presentation, it's pretty long, stating that HIV persists whatever therapy we have been giving. But on the other hand, preventing resistance will be the future question. I'd like to conclude stating that long-acting, high genetic barrier combination antiretroviral can be an answer. Today we have cabotegravir, we have rilpivirine, lenacavir. One is every 6 months, one is every 2 months. I'm not sure that whether this can be a good answer. It's an answer, but it can be a good answer. How we can develop, like our TLD, tenofovir, lamivudine, dolutegravir as a single tablet, how we can have a combination, long-acting antiviral so that our patients will be immensely benefited. We'll be able to suppress this virus and maintain this viral suppression for a long time. But on the other hand, we should never forget that whatever good regimens we are using, we need to continue to do both individual level and broader resistance surveillance in both for integrase and as well as cabotegravir, which is currently getting expanded in our regions. Again, at this time, I'd like to acknowledge several individuals who helped for my presentations. Matthias Jäger and Mamata from our DTG Resist, they shared generously the unpublished data from our studies. Marco Vittoria, a friend from WHO, gave some inputs. And of course, thank you so much to Gail, Tony Keller, and Kathy for our continued collaboration on from various second line and depth study data which I showed. And thank you so much again, Anjali and Steve Kerr and all my HIV-NAT friends for inviting me to do this prestigious David Cooper Memorial Lecture. Again, my deepest respect to David Cooper. Thank you so much.